Right, so hi everyone. Today I'm recording, the second episode of my podcast with Kieran. So I'll start off by making an introduction to Dr. Kieran Le Plastier. So in today's podcast, I'm having a chat with Dr. Kieran Le Plastier about some interesting ideas from the field of behavioral psychology. These ideas come from the book Thinking Fast and Slow by Daniel Kahneman, and Kieran's been mentioning these throughout my GP teachings, which I'll get to in a bit. But just an introduction to Kieran and his background. So Kieran graduated from Monash University in 2002 with honours and has been a practicing physician for 20 years. His career has included training with College of Surgeons and College of Psychiatry before completing his fellowship in general practice. His Ph.D. undertaken at the University of Western Sydney was an inquiry into the impact of the 4-hour rule in hospital emergency departments in Australia, which uncovered a rich and uncertain sense of epistemological and ontological basis of why we do what we do in medicine. Kieran is also the author of the book Managing Complexity in Healthcare, which introduces the complex, entropic, and ethical model which underpins how things get done in healthcare. I've had the privilege of knowing Kieran from my general practice rotation, where he was my lecturer. I found his lectures deep and thought-provoking as they touched on the subjects of medicine, philosophy, and psychology. In one of his lectures, he mentioned the ideas of System 1 and System 2 thinking from behavioral psychology, which were also mentioned in one of my favorite books called Thinking Fast and Slow by Daniel Kahneman. So I decided to do a podcast with Kieran to have a more in-depth conversation about the ideas from this book and their practical applicability in our lives. Additionally, I wanted to use this opportunity to ask Kieran about his own personal journey into medicine, his opinions about our healthcare system, as well as his book and his complex theory. In addition to that, it is the Pride Month, and I wanted to talk about the topic of LGBTQI and Kieran's own personal experience. So without further ado, I will pass it on to Kieran now.
Thank you. Thank you very much, and thanks for having me along.
It's a privilege and an honor, Kieran. And how has everything been so far for you?
Well, Bond's been a great experience. So I started here about 18 months ago.
Yep.
And I'd been working in Western Queensland as a GP in a village out there, looking after the town and the surrounds. And I always wanted to return back to the coast. Very much a ocean baby, so I like to be close to the water. And came back here, and it's been a great fit, actually. So wonderful university, lots of academic freedom, which is important. We need to be able to think freely, and then working with the medical students is, it's a privilege in its own way. For doctors who are out there working at the coalface every day, it's actually really nice to come back and be reminded what it's like to learn. Yeah. And I think students don't realise how much we learn from you.
Yep.
And we take that back out to our practice.
Yeah.
Particularly some of the assessments we do in general practice.
Yeah. Where
we ask you to analyse papers and represent them. You actually teach us a lot. So it's quite a reciprocal relationship.
Yeah, and Kieran, I honestly love that. And I think I was reading that about your biography somewhere, that you have this approach to like student-centered learning, that it's not just, a teacher who's just giving education to the students. It's a mutual, reciprocal interaction.
Yeah, and I picked that up from Freer, who's a great thinker about learning, and his work looking at the relationship between student or pupil and master, and realising that we have to equalise that relationship. So rather than a pedagogy where it's someone knows and someone has to learn, we see the equality first. And then from that place, we discover what we want to know together. And the approach in the lectures in particular, we have a lot that we have to get through technically, because there's a lot you need to know as a doctor, and you have to know technical things. But we try and embed that in an understanding that there's a relationship at the core of everything we do in healthcare. So the relationship between you and me, the relationship between you and your patients, and the relationships that your patients have outside of their relationship with you. All of that matters, and that's part of the work I do.
Yeah, I see. And what would you say made you get into, I guess, this sort of thing you mentioned, Frio? Frios. And with regards to, I guess, what you talk about in lectures, like, on epistemology, ontology, metaphysics, what made you get into philosophy and psychology, and like, where did that start?
I do make a fuss about ontology and epistemology, don't I?
Yeah.
I think it came from my own lack of knowing. So certainly in medical school, the technical aspects of learning I found quite difficult. It wasn't presented in a way that I understood, and I'm not here to talk about learning styles and things, which is actually a really uncertain idea, perhaps very popular but actually equivocal in terms of its research. What I was unable to really digest was I couldn't relate the information to the people I saw in front of me as patients. And it wasn't until about fourth year, I did a 6-year undergraduate degree, it was about fourth year where I suddenly realised I wasn't dealing with an abstracted idea of medical knowledge. I was actually trying to understand another person's experience. That really turned a key for me. And then in my last 2 years, I spent all of my time on the wards. I would, of course, go to lectures, but I spent all of my time on the wards, where I learned to relate to the patient. And then I just got lucky. I had some wonderful supervisors. I had some amazing mentors. And I saw the humanity in their work. So I became curious about that humanistic aspect. So we talk about technocracy, which is that sort of technical skill and even artistry, which separates the expert from somebody else. And it's very important, but there's a reaction against that certainly in Western culture over the last 60 years or so, that being an expert doesn't give you any special privilege. Your humanity is what privileges you. And yet we still need experts. Not everyone can be a doctor. Not everyone can practice what we do. But we have to do that humanistically. And so I was just fortunate enough that I bumped into enough people along the way who said, yes, we agree, that's important. So learn your stuff, learn your facts and figures, and then you must learn how to relate to people. And that takes years, well past medical school.
Yeah, I see. And would you say that actually learning about these certain concepts from philosophy, psychology has made you a better physician as you see yourself today?
Yeah, so one of the most significant moments in my life was realising I was going to be a very successful and unhappy surgeon. And there's a lot of successful, unhappy surgeons. Not all. Most surgeons are wonderful people and they're wonderfully skilled and have very happy lives. But you have to marry that job in a way that I wasn't actually prepared to sacrifice. So although intellectually I'd always been curious about the body and wanted to understand it, there was a point where I had to decide, is this what I'm going to commit my life to? And in that moment, I didn't hesitate. I realised, no, actually, that's not right for me. And some weeks after I decided to take a break from surgery training and just do some general internal medicine, a charismatic psychiatrist and I bumped into each other. He said, you should become a psychiatrist.
Yep.
So I did, and that's what I did. And it was one of the most important parts of my career training was the discipline of psychiatry. So I'm not a psychologist. It's important to understand they are different things. For any listeners who are uncertain, it's not just about script pads. It's actually a way of thinking about problems. And psychiatrists think about things from a pathological point of view. And that's really important because it changes the way we frame things. And in that discipline, though, I did a Master's of Psychiatry at University of Melbourne and met some extraordinary medical philosophers in that time. So I've just been lucky, I guess. I mean, I've made conscious choices, but at the same time, you don't know what the future holds. And I've been lucky that at really important times it's delivered opportunities to hear the world from a different point of view and to be inspired by that. And so psychiatry, particularly the philosophy of medicine part of that master's, was really influential. And definitely helped me understand the parts of the relationship I didn't get in medicine with the patient, and to improve on that.
Yeah. I was going to delve into this topic later, but I guess since we are on this the topic of change of career that you had into psychiatry, what made you change from psychiatry into general practice?
Yeah, so going at the other end of that, so I spent many years in psychiatry training, and then I had a break in training to explore an opportunity to work for one of Australia's medical defence organisations. And there was a group of people in that organisation that realised that the way we were trying to approach behaviour change amongst physicians, particularly physicians who might have been at risk or who had been found to do something negligent, or their behaviour was really borderline, we had a responsibility to our peers to look after them and try and find ways to improve. They were looking for a different way, and I was looking for a different way. And so we came together and built a program together, which ultimately was very successful. And we won an international television and film award for one aspect of that work, because we were dedicated to doing it differently. And we were all very keen on doing things well. And so that kind of success breeds success. And that program introduced me to thousands and thousands and thousands of junior doctors, medical students, and consultant physicians across the country. I worked all around Australia over 5 years. And then returning to psychiatric practice, it had changed. So I'd done that for a few years, and the concept of mental health has really taken a turn. And psychiatry is now about mental health, which is not the same thing as psychiatric illness. And they've been melded together for all sorts of social and political reasons, and I'm not going to commentate on that today, only to say that what I witnessed change in the way that we approached mental illness in particular. There were many deleterious effects, including that we sort of had this idea that all mental health issues were equal, and I just don't share that view in that, particularly the 1%ers. So things like schizophrenia, bipolar, these profoundly disabling mental illnesses were used in the same breath as depression and anxiety, which can be disabling, don't get me wrong. And it affects many more people, of course, but that relative consequence was perhaps becoming lost, and lots of efforts being made on popular ideas rather than the issues that require medical expertise. And so over a period of time, I just realised that permanent psychiatry practice was probably not right for me. I probably would have ended up in the private system. I didn't really want to be a private consulting psychiatrist. I still wanted to work in the public and work in the coalface. And that's not to diminish private psychiatry. They do extraordinary work changing the lives of, thousands of people. But it wasn't what I wanted to do. And so, again, a series of conversations with friends and peers, and an old colleague bumped into me. He said, well, you can do psychiatry and be a GP. And guess what? You can also do a bit of operating, and you can do skin, and you can actually do anything you want in general practice. And that was really it for me. I was like, well, that's actually quite true. So I left being a well-paid senior medical officer and went back to registrar salary and did registrar training for 2 years. And, I've never regretted it. It really is the right place for me.
I see. And do you love, I guess, the whole of medicine? Or would you say if, say, psychiatry was practiced differently, you would have been a psychiatrist today?
I might still have been a psychiatrist, but I actually really love everything that we can do in medicine. I think it's extraordinary. We are so profoundly privileged to be expert in something that can inject such hope and opportunity and recovery into the lives of other people. That's a privilege. We're just the vessel for the way of knowing and the way of thinking. So we're not important, but what we do is. And, I never forget that privilege. And when I do, I know that it's time for a break, that's when I'm getting into burnout territory, when I start to forget just how lucky I am.
Conversation about that. But I'll move on to the topic of this conversation, which was thinking fast and slow, and talking generally about System 1 and System 2. So just to give a one-sentence summary of the book. So thinking fast and slow shows you how two systems in your brain are constantly fighting over control of your behavior and actions, and teaches you many ways in which this leads to errors in memory, judgment, and decisions, and what you can do about it. So I guess with that in mind, I would love if we could talk about System 1 and System 2.
Yeah, and for listeners who haven't sat in on one of our tutorials, it's something I think is very important for us as technical experts to understand, is that the way we think can so profoundly shape the framing of what we see and what problems we think we're trying to solve. And once the problem framing is established, then solutions seem to manifest. So of course, if we step backwards and say, hang on, if the framing's not right, then that means the solutions can't be right, because the solutions are solving a frame of reference which we have to acknowledge is incorrect. We can't always know, right? So we have to be able to be flexible to say, well, I think this is the problem. And then we have to be able to work out, is that the problem? And confirm it in some way. And the fast way of thinking allows experience and certain unconscious or pre-conscious modes to quickly decide that this is the problem and this is the solution. And of course, the type 2 slower way of thinking requires a much more analytical approach, which says, well, I have some elements that I understand, but I'm not quite sure yet how it all fits together. And so that demands a lot more attention and focus. Broadening from type 1 and type 2 thinking is work by Friston in the UK, which suggests that even beneath those ideas is a much more fundamental, almost mathematical relationship, which is built around entropy. And you've mentioned, and I'm sure we'll talk about it to come, is that the universe is ultimately some uneven distribution of entropic forces or functions, and as a result of that, things can happen in one space, but they can't happen in another space. And inevitably, everything expands to maximum entropy, which is maximum loss of information and relationship. But we're a million miles from that on planet Earth. We're intensely low entropic. And our thinking allows us to use very low entropy systems to make decisions. Yep. Or we have to burn more energy fundamentally. We have to consume more energy to think critically. And as a species, we're primed to do as much type 1 thinking as possible because it's efficient.
Yep.
It's not energy demanding. We talk about words like easier and harder, and I think they're quite pejorative. There's nothing wrong with taking the easy solution. That's a moralistic, perhaps religious idea that the easy path is not the right path. I'm not interested in those kinds of epistemologies. I'm much more interested in the science of it. And so it makes sense that you want to choose easier path. But as you've alluded to, our behavior, our choices, can be influenced deleteriously by faults in one or either of these systems.
Yep. And have you seen any examples of that? Like someone's doing System 1 thinking?
I do it all the time myself.
Yeah.
So I don't need to look outside. I just look at what I do.
Yep.
And just recently I was consulting a patient, and I made a very quick decision that this person was cognitively intact and that they had competency to make decisions about their healthcare issues, when there were broader activities at play where an enduring power of attorney had been activated for health and finances. Now, that doesn't mean I have to go to the EPOA. It means I have to make an assessment based on what I see with that knowledge. And I made a very quick decision. I said, well, this person competently agreed to certain set of tests. The results of those tests actually are unfortunate. They do point to the possibility of cancer. And I need to talk to the patient about what next, because that person had already decided knowingly, and I'd assessed them as such. And within about 15 minutes of that consultation, I phoned the enduring power of attorney to discuss the issue. And they were very angry. You had to talk to me first, they demanded. You've broken the law. I'm in charge. Now, whether or not that thought is correct is not relevant. What's important is that I was operating on a very fast thinking style because I needed to get to the next 25 people I had to see that day. And that was playing on my mind. So quick rule of thumb, person's competent, I can discuss it with them, and then I follow up.
Yep.
All it would have taken is having that phone call first with an interested person who has a very important role to play in this person's life. And it would have been a different outcome, because I would have been able to explain to them about why I was going to talk to their loved one about this issue, why I wasn't going to be beholden to them because I'd made the assessment the patient was competent. So, and I do that all the time. I don't make mistakes like that all the time, but I have to check and balance those ways of thinking all the time.
Yeah.
Even when it comes to prescribing an antibiotic, deciding whether to send someone to hospital. There are quick ways of thinking and there are slower ways of thinking. Neither one is necessarily right or wrong. It's the context. The context is really important.
Yeah, and just relating to that, I was pondering on this idea myself. So we say that it takes 10,000 hours to become a master at something. It takes usually 10 years to accomplish that, it's said. And at that point, it's said that across various different fields, the masters use their pattern recognition to actually engage in the system one thinking. They're not thinking about all these books and concepts they read. They look at something, in the case of a doctor, look at a patient, and are able to pick up on the history and physical exam and make a quick diagnosis and quickly treat that problem. I see that as a very useful and skill.
It's very useful, especially to society. It means we can see lots more people.
Yeah, and is that something you agree with? And is there a positive example of that you've seen in your career yourself or in? Yeah, so
another one just from the weekend, I saw two young people, 14, 15 years old, and I used this example yesterday in a lecture, and I said, within 35 seconds of arriving at the house to see these young people, I'd already decided they were getting antibiotics. And I put it to the group, how could I have decided that? And I could decide that because they had Aboriginal and Torres Strait Islander heritage and they had sore throats. And in that setting, the risks of the complications, without boring our listeners with detail, but the risk of complications is higher in our First Nations people from sore throats that are bacterial. And so antibiotics are indicated, and they're indicated early, and they're generally indicated based on clinical assessment alone. We don't have to do swabs and PCRs and things. So that was a very easy decision. I'd already decided. And what I then had to do was to just be careful I didn't miss anything else, because I had First Nations young person with sore throat in my head. That's not even a second's thinking. But hang on, there's a bunch of other things that sore throat could be. So you have to slow yourself down. That's the discipline of medicine, is to acknowledge that even though I know the answer pretty confidently before I've even spoken a word to the patient, it's very important that I check that hypothesis test. And so I did that, and that consultation didn't take very long. So it's efficient and effective.
Yeah, and I think that's a perfect example of perfect example of system one being useful, but at the same time keeping system two in mind as well, and actually exploring various other things that could go wrong in that case.
Yes, that's right. And I think diagnosis is the art of the two systems. So we need to generate an hypothesis early to be efficient, and type 1 does that very quickly for us. Our scripts, our experience tell us this is the likely diagnosis, and then we must spend time trying to reassure ourselves that that's correct, and we use a slower process to do that. We tend to make mistakes when we forget to check ourselves, and Jerome Groopman and others since the early 2000s, their research shows that the simplest question a doctor has to ask themselves to prevent or reduce the risk of an error is, what else could this be? And so that's one of those iconic statements that we need to teach ourselves to ask every single diagnosis. What else could this be?
What else could this be?
And that allows our type 2 analytic processes to engage. We have to train it to do that. It doesn't happen just because we say it.
Yep.
That could just be another one of our quick heuristics. What else could this be? Not really attending to it. We actually have to take the time to attend and say, what else could this be, in a very deliberate way. But that statement, more than many other complex interventions, there's some evidence around checklists and other things that slow us down. But actually that statement has been time and time again shown in the real world to be really useful. What else could this be?
Yeah.
But how do you know what else could it be? That's what medical training is for. Mm-hmm. How do you know that there's actually 10, 12 different things that you need to consider for that constellation of symptoms? And that's the struggle, and that's the suffering of the student, is that, or the learner, is that you can't know it all to begin with. It takes years and years and years to accumulate that. And so I do remember my frustrations, deep frustrations on ward rounds, 2 or 3 years out, watching my consultant colleague walk in, and within 35 seconds it's all sorted out, and just going, I'm never going to be able to do that. Yeah. But it's in part because it takes many more years than medical school to know all the possibilities, and maybe not even all of them, but all the really important possibilities of what else could this be. And that's part of our job. Yeah,
amazing. I just wanted to summarize System 1, System 2 based on what you said. So System 1 is a fast system thinking. So it's defined by characteristics such as unconscious, effortless, automatic thinking. It's the one that goes on the automatic pilot mode. System 2, on the other hand, is the slow system of thinking. Its defining characteristics are deliberate and conscious thinking. It's effortful, and it's logical, it's lazy, and it takes effort. It's rational thinking, basically. So I guess based on that, I would like to then go on to some of the biases that we can talk about, some of the specific concepts that are discussed in Thinking Fast and Slow. So one of the first concepts I wanted to talk about was halo effect, which is that the person who's affected by this effect considers only one aspect of a person or a product in order to form a general opinion. So, for example, like I could look at Kieran and say, well, he's dressed very handsomely. He looks like a professor, and so whatever he says, it's it's going to be smart. It's going to be logical. It's going to be something that I believe and I trust. Mm-hmm. So just based on, I guess, the phenotype or the physical appearance of Kieran, I've decided all of these things about him. That's, I guess, an example of halo effect.
Absolutely.
So,
and in medicine, it's very, very common. One of those things which I've seen go badly too often is we learn all these rules of thumb, these shorthand ideas. And one of them is that, reproducible chest pain isn't cardiac. And I've heard junior doctors for the last 20 years when I'm perhaps working in the hospital system, coming up and saying, it's a reproducible chest wall pain, so it's not cardiac. And then I usually try and pull out 6 or 7 cases where it was cardiac.
Yeah.
And so they're really helpful. We can very quickly deduce all sorts of possibilities, or distill out from all the possibilities all sorts of probabilities based on that halo. But it's the testing of the theory that matters most. And so that's the problem I see too often, is that we allow the first impression or the single bit of information to define a whole range of possibilities, we make them probabilities, and we overvalue the probability. And as a result, we don't check ourselves. And that, I mean, it can be catastrophic. Blessedly, the world tends to be a bit more forgiving than that. And so we just make a mistake, and we can recover from it. So as far as biases go, I think you've probably hit the nail on the head about one of the key ones, which is we will have 3 or 4 symptoms described by the patient, but focus on one. And then we use that to just justify everything. That's problematic. It's not taking account of everything.
Except it's weird in a way. I don't see a problem with that because I'm just so used to doing that myself.
Mm-hmm.
So
yes, indeed. And so these things are probably hardwired, aren't they? So they're in the way we process information, and they must serve a purpose because they've survived. So they've survived millions of years of evolution, and so we have to respect them. They're there for a good reason. I imagine not being, at the point of visual acuity becoming problematic, and there's something on the road ahead that's long and thin. Well, I can assume all sorts of things, but the thing I don't want to miss is that it's a giant snake lying on the road sunning itself that I don't want to get anywhere near. It sounds like a really reasonable assumption to make from a single bit of information from our visual acuity. It sounds quite reasonable as a survival advantage.
Yep.
And it might also be pro-social. I mean, it's stereotypes work. What we've learned is that stereotypes frequently aren't relevant. So the probability isn't very high. But many stereotypes, the probability is better than 50%. That's not a bad probability on which to base a bunch of assumptions. But I think we're talking about something slightly more abstracted, which is we're thinking about thinking here. I think the important thing about halo is, in any bias, is that we're often not aware of it. That's a very different thing. Yep. We've just done something. Behaviour has happened in response to that information, as opposed to thinking about how that information was used. I think that's really important to highlight in biases, is that they're called biases because we don't see them.
Yeah. And I think the most important thing with any of these biases is just to be aware about it. So moving on to the next bias, it's called priming or anchoring effect. So that exposure to one stimulus may influence a response to a subsequent stimulus without conscious guidance or intention. So do you have a simple example of that for listeners? I'll try and think of one.
It's become, I must say, certainly I'm a slave to the biases, but through years and years of work in this area, you do become a little less unconscious about these things. So it is harder sometimes to talk about. I suppose that a simple anchoring thing that I'm quite familiar with is which side of the pavement I walk on. I always walk on the left side. I'm anchored by years of experience in Australia, where we travel on the left side, and you go overseas and you bump into things, and people in particular, and that happened to me a lot in my travels around the world, is that I bump into people, literally bump into them, because the anchor is so strong to move on the left side of the pavement. And so the built environment is so important because of this capacity for it to shape pre-consciously or even unconsciously, to shape experience. And so most of the buildings that I used to work in the public hospital system were like really drab and boring spaces, terrible places to be. Terrible places to be because you're unwell and feeling terrible. But also they invited no other model of being. And, we know around the world, and certainly in the US, there are hospital systems over there that have completely redesigned to encourage wellness. So as soon as you step in the building, you feel more well. Isn't that extraordinary? And then you go and see your doctor, and guess what? You feel more well. So I think we underestimate just how powerful these these biases can be to be used for good.
Yeah, 100%.
And so I think I've seen that in my own life, that you walk into certain spaces in healthcare and all they do is make you feel better.
Yeah.
Before anything's actually really happened, and we know that how you think about your health changes your health experience, and so these things could be exploited a lot more successfully, I think.
And I think a great example of that was Aboriginal healthcare that you mentioned in our GP teaching, that we can start putting up like Aboriginal flags and artwork in general practice, and that can in this context prime the patients to actually feel welcomed. Yes,
that's right, and have our seating arranged properly and have staff greet people properly and all of that. So it's a complex issue around ensuring that your space encourages a sense of community and participation, because that will project into the healthcare experience.
Yep. Next bias was cognitive biases of availability and recency bias. I was thinking about this in the context recently of social media, that how it just exacerbates what we already think about, just shows us the same stuff. If I'm a fan of Indian music, it's just going to show me Indian music. I'm a fan of Trump, it will just show me Trump. It will never show me the other side of the... I'm not a fan of Trump, but...
Well, whether you are
but just an example.
But I understand your point, which is yes, the algorithms are very good at this. So algorithms are very good at predicting based on the available information. What has happened most recently, they're very good at predicting what you might want to see next, which is something that we're all prone to. What I love about general practice, of course, is I have undifferentiated healthcare. And so that's actually quite fun. I don't think I was mature enough early in my career to deal with that uncertainty. I think I let go of needing to be right over a number of years, which allowed me to sit with uncertainty a lot more successfully. And as a result of that, undifferentiated illness became much more interesting, and it's actually really enjoyable. But I can't understand why people don't like that idea. But when I was, working in, say, a psychiatric unit, the person that got through the door was selected out. And so they're almost always going to have a mental illness. And a certain type of mental illness. And so you see people and that's all you see. And so that becomes your availability bias. And you don't see the person. And you don't necessarily see all this other important and rich dynamic information, which might change the shape of how you think about things, because that's what's happened for the last 10 cases or the last 30 cases. And we know there are diagnosticians out there who diagnose rare and unusual conditions at a frequency which is improbable.
Yeah.
Cardiac abnormalities, and there's a couple that come to mind, but I don't want to say them out loud because it's a bit pejorative. Yeah. But fundamentally, there's these diagnosticians that only see certain. And you go, well, just based on probabilities, that seems unlikely, and yet that's all they're saying. So we know that it works. That you can make it. You can make it seem to yourself that everything that walks through the door is one particular diagnosis, and that's the availability. And there's a tragic case of that in my own experience with a colleague who had a terrible outcome with a epidural abscess that got missed, and the young person died. And it was terrible, and the young person came in with back pain and got treated for acute lower back pain. Nothing controversial about that. But what was missed was the elevated white cell count. It was ignored. And subsequent to the patient coming back to hospital some days later very unwell, there was a very high CRP, that inflammatory marker. And so this doctor then did full blood counts and CRPs on everybody that came through the door with low back pain. And because it was such a profoundly negative experience, it just coloured everything they thought about patients walking in with back pain.
Recency bias in that case.
And in that case, reinforced by the emotional trauma of missing a diagnosis. Yeah,
I see. And I mean, in that case, maybe, I guess it's important. You may say, or it's, I don't know, rational, irrational. I'll leave that to...
Yes, and I don't think it's irrational. I think we delude ourselves with the idea that we're rational beings. We're not. We're emotional beings. And there's a lot of wonderful research coming out that says that decisions are emotional first, because of the structures involved in the initiation of action that are pre-awareness. They are emotionally based.
Yep.
So we actually tend to do things that feel good, full stop. And so to avoid feeling bad is, I think, also a really important motivator. And in analytic thinking, it's the most important element. It's the reality principle. We go from the pleasure principle, seeking out pleasure at all costs, to the reality principle, which is our pleasures can't be met. And in fact, the world is hostile. And as a result of that, my best strategy is to avoid suffering. And so that's the reality principle. And I think it's true. But they're emotionally based, and we should embrace that, because that's the reality. That's how we decide.
Yeah.
We then rationalize after that. And I think we do well to remember it. And certainly the Stoics knew this. They knew that everything was emotionally based, and then you had to engender some activity to think about why you've decided something. So rather than, it's not being devoid of emotion, it's acknowledging that it's the first, it's the a priori to all action. Is emotion. So once you accept that it's the a priori, you then have to have a system in place to reassess whether it's still the right decision or not.
Yeah, no, that's really cool.
Yeah.
And I'm not too sure about the stats on this, but I think a resource said that we do system 1 thinking about 95% of the time, and system 2 thinking is only like 5% of the time.
Yes, and I am aware of that idea. It's sort of the same idea as we only use X% of our brain power. I don't really know whether we know enough to say that. I think if you're talking about decisions that involve action, perhaps that's true, but the brain, the mind, it's never off. So I'm not sure about that, because in dreaming is a densely and extraordinarily sophisticated form of thinking, and there is no action in the external world for that. Perhaps we roll over in a bit of panic, or we stiffen with fear in our sleep, but fundamentally that's still an enormous amount of energy being consumed in what I think is quite sophisticated analytic thinking. So dreaming is a very analytic process. So I respect the author's thoughts, but my experience suggests, is that really the sum total of it?
Yeah, I'm not too sure if the author said that himself. I think it was an internet resource I just looked up out of my own interest. Causes and statistics. So people feeling more influenced by an emotional case versus a statistic.
Well, we only have to reiterate what I just said, which is that all decisions are emotional first. So it's primed in the deep structures around the hippocampus, the amygdala, the prefrontal structures, our somatoform parts of the brain, so those representations on the brain for our body. These things are instrumental in initiating the action potentials that lead to what we sense as thought and action. So they're well before the thought and action, milliseconds before. If you consider that all things in the brain are happening at the speed of light, there's a lot going on that we don't see and can't measure. But in this case, we can measure it because it's long enough, the latency is long enough for us to see. So there's a lot going on in that latent period, which are these structures at play. And so, emotion is fundamental to that process. So we should embrace it.
And I think relating to that, an example that author gives in the book is about patients interpreting statistics with regards to a treatment being offered, or the chances of survival. Like, I don't know, patient being told that the chemotherapy that will give you has a 5% chance that you will die at the end of this. So 5 out of 100 people die, and versus another patient being told that, well, there's 95% chances of survival, so 95 out of 100 people will survive. I think the author sort of notices that in that frame of thinking, you know, patients tend to make different decisions based on those two statements.
Yeah. And remember that neither of those statements is actually framing the problem correctly. People are going to live and die. That's not in our power. What we should be curious about is what matters to the patient. So if you have chemotherapy and you've got a wedding you want to get to in 8 months' time because this person means the world to you, this is the opportunity to do that. Not 95% survival, 5%. What is it that really matters to the person? And being alive and dead, after 20 years of practice, I'm quite confident that for the vast majority of my patients, even those who are actively dying, as we acutely say in emergency, they're actively trying to die, they're not worried about death. They're worried about suffering. They're suffering, and they want to know, will the suffering end? And if the suffering ends, is it going to end with no further suffering, or is the suffering going to persist? And so a person's quality thinking is not interested in the statistics of survival, which is interesting to us as technocrats. It's what's the purpose of it. So if we ask the right kinds of questions and elicit those ideas from our patients, we're actually better at helping them decide what to do. And remember, it's not our decision, it's their decision. The only time it's our decision is when they're incompetent, when they're unconscious or suffering some kind of delirium or some other impairment profoundly on their judgment. We are enabled in limited circumstances to make decisions for them. But really, we're talking about people that get to decide for themselves. And years of seeing people do irrational things that turn out to be perfectly rational. That's when you get over yourself. That's when you let go of being the doctor who's right. And when you start to realize you're just in service. You're actually in service. And they're not consumers and customers in the traditional sense. I understand why there's a push to label things in that way. It's about disempowering the automatic power relations that occur when we say doctor and patient. But actually, I find that asymmetry is real, whether you like it or not. And to deny it is actually dangerous. And it's focused on the technocratic aspect. Good doctors are humanistic. And so we don't need to worry about the power asymmetry of patient-doctor, but that's what we are in relationship to each other. I agree. And so when we're humanistic, we become much more interested in those other things. And so I've just found, and patients have taught me this. You can't learn it any other way. Patients teach you about why the decisions they make are the right decisions and how they can seem irrational, but they're emotionally crystal clear. And when you bother to find out, your work becomes much more interesting because you're not attached to the numbers, even though it's your job to explain those numbers to people. Yeah.
I guess how I would integrate it into my thinking is that from what you've said, it's important to recognize the goals, values, and beliefs of the patients and align your treatment in accordance with that. But I guess based on, the fact that people will make emotional decisions first before they make rational decisions, I guess, I see the importance of saying things in a certain way so that, they're more likely to be taken up by the patient. But I don't say this in like the sense that, because I'm a doctor, I want this to be taken by the patient, so I want,
Well, I think though that's what we do want.
But I think I agree.
We're allowed to want things for our patients.
I agree, because
we're allowed
isn't
to want
it
them
right
to make the decision.
Give them the treatment?
Yeah, we're allowed to want them to take the treatment, right? Because we know it's got the best chance of helping them out. So we're allowed to know that, and we're allowed to feel that. I think the issue is the dichotomization of emotion and rationality. All rational thought is emotional. Is what the research shows, and certainly what my experience working with humans has reinforced over and over again. All rational thought is fundamentally emotional. So that sense of rationality is just a means of checking that our feeling is the right feeling, because we acknowledge that feelings come from all sorts of different experiences, which may not be totally relevant to the circumstance we're in right now. And that's what doctors do, is we say, okay, patient, you're in this circumstance right now. Your emotions will be driving you to avoid suffering, to want to be free of some disease, blah, blah, some of which can't be done. We actually can't. We've got to harm you to make you better. We've got to accept that there's limits to what we can do. We've got to accept that the treatment will or is failing. And how do you meet the emotionality of that without tricking yourself into thinking it's fundamentally about the numbers, it's fundamentally about the logic.
Yep.
And I'm still learning about that, but I'm probably better at it now than I was as a young doctor. I was infuriated by my patients, genuinely infuriated. I'd go home and go, bloody so-and-so, why can't they just see what is so obviously the correct choice?
Yeah.
And through supervision and good doctors reflecting, experienced doctors go, I understand. But what does the patient want? And I go, what do you mean? What is it? But the patient wants to get better. Do they? Is that what the patient wants? And it's not that they don't want to get better. It's that that's not what's driving their choices. And, okay. So then how do I make sense of that? How do I make sense of what they want versus what I think they need, versus what the numbers tell me? And that's their non-computable problems. An algorithm can't sort it out because you can't ultimately break it down into chunks that can be computed. Multiplication of factors and factorization doesn't work because that's not how these decisions are made. And it's why doctors still have a role at the center of healthcare with patients, because computers can't do it.
My laptop's just about to run out of battery, so I'm just going to connect that to the to power. But I guess we'll take a short break, and my next question to you is relating to that. If you could, go through a story that you told us in the GP teaching about how you came to the realization that, it's not about you at the end of the day. So, cool. I guess if you could go into the story that you talked about in the general practice teaching about how you realized it wasn't about you, and that philosopher you met?
Yes,
professor?
He was a professor,
yes,
and also a philosopher. Very, very fortunate. Who has written some stellar work on the nature of ethics in medicine. Professor Paul Komisarov. And I was very lucky that he was one of my key lecturers at medical school. But as I said in the forum that day, in my medical school contact with his way of thinking, I found it very frustrating because we would talk about ethical principles, and we would compare and contrast the different choices you make based on those principles, and ultimately you would come to some decision. And I would try and compute the ideas, so autonomy, beneficence, non-maleficence, and justice, which I have a quite strong view about these days, but nonetheless that's what we were taught growing up in medical school. And so it just seemed to be a contest where you had to calculate the variable influences of these ideas, and then you get an answer. And we would get to the end of our lectures and I'd say, but what about? And his response would always be, well, it depends. And I just found that enormously frustrating. I understood that there was something really important to get, but I didn't get it.
Yep.
And so I found biomedical ethics very frustrating.
Yep.
And I found that I became quite didactic in my understanding. And I'd apply that in real life. So for my first few years of medicine, all decisions regarding consenting for patients and whether they have an operation or not, and whether or not we do this or that, or whether or not this person was competent or not, were quite binary exercises. You just had to work out the answer, and once you had the answer, you knew. And it wasn't until I was in psychiatry training again at the in the master's program, and I came across Paul again in a different context. And we were in this forum one day, and he was chatting away with a wonderful palliative care colleague who I was also privileged to train with for a few months at med school. And he was talking to the group about, issues related to these ideas, autonomy, and doing the right thing by patients, and how you make sense of all of that. And he just said one thing. He just said, remember, it's not about you. And I had a light switch moment. It was so profound. I was shaken, absolutely shaken by that phrase. Remember, it's not about you. And I know when you hear that in dissociation from the context in which I heard it, it can sound fairly glib, almost a truism. I remember, it's not about you. But in this particular moment, it uncovered my eyes to the fact that in processing all things about the sort of ethical dynamics of some dilemma, I was only using my brain to sort it out. And the thrust of what he was getting at was that there is nothing you can do ethically that is not contingent on the relationship in which it's happening. So you can't make an ethical decision on somebody else's behalf. You can only do that together. And that was the moment. I was like, oh my heavens, it's not about me. It's not that it's not about me, it's that it's about the relationship. It's about things that happen within that relationship, which are so infinitely complex in some respects. There's that word infinite again. That just means we don't know. But intensely complex to the degree which you could never really properly disambiguate how that decision came to being. But you both kind of work out, it's the right decision, that emotionality, the feeling. You know the feeling. It's like, oh, that's right. It's a feeling. And you can't have that feeling. You can't have that experience alone. It has to be with the patient. And yes, admittedly, sometimes the patient's unconscious at the time. That's a different kind of ethical dilemma. But for the vast majority of our work, we're dealing with somebody who is lucid and engaged and present, and you're in relationship with them. And that completely and utterly changed my experience of medicine.
Fantastic.
It became an unabstracted concept that there's the patient-doctor relationship, to understanding that it's the patient-doctor relationship. That's basically where it begins and ends. And everything that happens within that is profound, and it's mutual, and it's reciprocal. And so I can have my needs met in that relationship, the patient can have their needs met in that relationship, and together we might actually do something really constructive. We might also do something quite destructive, unfortunately, but that's actually my job. My job as a professional is to say, hang on, this feels like it could become a problem. And whether it's prescribing a drug of addiction, whether it's recommending hospitalization for a person with a personality disorder, or whether it's having therapy with somebody and realizing that the boundaries are, something's going funny at the boundaries. My job as a professional is to bring that broader capacity to reflect on what's going on and see opportunities to improve, but also opportunities where it could be falling over. And that's what I'm paid to do.
Yeah. And I think that's a fantastic insight. I certainly loved hearing it during the lecture, and I loved hearing it now as well. So
yes, I hope we all get sort of the odd light bulb moment in medicine. We certainly need it.
Yeah, and it's cool how it can just happen like that.
It's
just
quite extraordinary, yeah.
Phrase. Kieran, I sort of wanted to delve into the LGBTQI stuff that I wanted to ask you. And I wanted to phrase this as just a general question, and you could talk about this. So we're in the Pride month of June, and I've been having conversations with my friends about this topic, and we seem to have quite a diverse opinion about what this whole idea means. Like, I sort of approach it from the idea that that people are different. There's neurodiversity. Some people are homosexual, some people are transsexuals. Obviously, it's a heterosexual. That's the current norm or the majority, but it's changing as we're seeing. But I'm sort of coming at it from a position of that it's the individual who's representing their authentic self by coming out, and we as a society should accept that. Some of my friends think that no, it's a mental health issue that needs to be treated through medication, through psychological support, through counseling. Some say it's an attention-seeking behavior, that you're just seeing this rise of people who just are just saying that they're
identifying this way or that way.
Yeah, just for attention. So yeah, like, I just wanted to ask you, just as a general question, what is your opinion on this? What's your experience, if we could?
Yes. So this? And acknowledging Pride Month. Happy Pride to everybody. I think the first thing to say is that I have one overwhelming disability, and that disability is that I have a profound white male privilege. And as a privileged white male, the world does not respond to me in the same way as it responds to everybody else. And by virtue of that, I respond differently to the world. I am born into a world that was designed by me, for me. And what I mean by that is that I represent everything that generations of men have spent building into the structures of how society functions. And because of that privilege, it's actually quite disabling, because I don't see the world in the way that other people do. And just because my sexual orientation happens to fall into that band of minority, I, under no circumstances, represent that minority. And I think it's important to acknowledge right off the bat that what I talk about is coloured by that white male privilege, because the world didn't change very much for me. I had my own profound and significant personal crisis, which nearly undid me. But the world around me didn't really change very much. And in fact, it became almost a useful differentiating factor amongst the competing white males, which perhaps even gave me advantage. So where many people have to struggle or have to sacrifice so much to come into themselves and then to come out, I didn't have to have that experience, and I think it's important to acknowledge that. But I did have a very terrible time, and I had a terrible time because at a personal level, I thought in a very traditional Judeo-Christian way. I was brought up a strict Catholic, and the consequences of that, even after I'd left the religion, was that identity was wrapped up to a very tightly wound ball between moral responsibility and identity. And so who you are as a person very much determined your moral status. And so I had a terrible crisis. I mean, I nearly lost my mind. I had to see therapists, and I couldn't go to uni for a long time, had to have time off, and I really just sat in a ball on my sister's floor for nearly 2 months. I lost a huge amount of weight. I didn't talk to people. It was a desperate time. That was actually before I came out. So this was the crisis of recognizing, because I'd been in denial for most of my life, even though I'd known since I was a little boy that I was different. And I'd known since I was a little boy that the way that boys looked at girls was the way I looked at boys. And, you know, I'm unabashedly a fan of men. I just think they're extraordinary. I just love men. I just think they're amazing. And I love women too, but there's an affection, a strength of affection that I have for men, which was different from how I saw my peers growing up in a little country town in a Catholic school. I knew there was something wrong with that. And then I'd go to church and I'd be told that in a roundabout way, because they didn't use words like homosexual and gay back in the 80s. We didn't use those words. We would talk about abominations and we'd talk about sinners. And coded into that was a recognition about what that could mean. And I didn't know the word homosexuality until I was 15 years old, which perhaps many of your listeners might be surprised, but it was not a word I'd ever heard in my life until I was 15 years old. Oddly enough, in a religious education study group with a teacher who I have come to adore, when she just raised this, she said, "Oh, by the way, you know that there's men who love men and there's women who love women."
Yeah.
I remember sitting there, one waiting for the lightning bolt to strike from above as I go, "Oh my God, that's me." And that's a sin. Yeah. But that was the first time I'd ever heard the word. And then it was many, many years later. I was about 22 when I came out. But the crisis of identity was real. I mean, it actually fractured me in a dangerous way. It was quite dangerous. There was a point there where, death did make more sense. I didn't try and harm myself, and I didn't think about ways I could. I just realised that death was preferable to this unyielding suffering because my sense of self had fractured. That thing that had been solid all that time was suddenly no longer solid. It wasn't even a liquid, it was just fractured into 1,000 pieces. And then I had to rebuild. And I did all of that before I actually came out. That was just my way. But you have to understand that what happened from that point onwards was much more influenced by my privilege than anything else. And so, it just was seen as an affectation almost. Just another way that I was different. I was a bit smarter than everyone. I was blonder than everyone. I was all these things that were different about me. You talk about people being different. We're all different. But I wasn't different in a way that mattered to people moralising about it, even when I came out. There might have been the odd, well, does he have to go around telling everybody? I think was as bad as it got. That was the worst criticism I got. Does he have to go around telling everybody? And that is not people's experience. And
were you in medical school then? So
yes,
you said 22 years old.
Yeah, I was
crisis
in fourth or fifth year.
Yeah,
fifth year.
I see. And when did you come out?
I came out at the end of fifth year.
So like 23.
Is that right? No, it might have been. No, it was the end. It was the end of fifth year. Yeah.
Yeah. And how was it to then come out?
Well, I suppose I was in Melbourne then, which is a very gay-friendly city, and certainly we had our ghetto.
And so you went to University of Melbourne?
No, I went to Monash in Melbourne.
Sorry, yes, Monash. That's where you did your honours. Yeah.
But Melbourne had a really wonderful ghetto in South Yarra, which was a very safe place to be, and so that's where I came out, and that's where I basically spent the next 4 or 5 years of my life, was with my friends and some family, but certainly with my friends in that part of Melbourne, just learning what it meant to be me. Yeah.
Would you come a bit closer to the mic? Sorry. Yeah. I see. And you're saying that I guess that experience which you had, it's different the experience that other people have with there's some shared elements.
Yes. Well, I imagine the identity crisis is probably shared. Maybe people don't have those same sorts of intensities, but I certainly see that we all, in my cohort of young men at that time coming out, we all had to deal with the sort of crisis of identity, and that was true for all of us. And it was a foundation upon which friendships were formed, because we kind of understood.
Yep.
But then what happened after that was much more materially affected by race, colour, social standing, all those sorts of things. And so for me, I'm at the top of the pile in white man privilege, doctors are still considered quite important people. Automatically, we talked about that earlier, all these assumptions are made about my goodliness. And so I just didn't have to suffer further beyond that.
Did it change the way people treated you, and did it change the way, I guess, you treated people, that the way you perceive the world, as we were talking?
Yes, I think the first thing is that it changed me as a person in terms of seeing the diversity of people around me. And that's even in heteronormative people. So you can still be gay and heteronormative. It's not the same as heterosexual. Yeah, so heterosexual is your sexual identity, but heteronormative is you still want the white picket fence with the children and the dog and the car and the nice house. Yep. So that's a heteronormative kind of thing. And I think many of us are still very heteronormative, and I'm certainly fairly heteronormative in that way. But the gift of coming out is that you get to test out whether that's really you or not. And I certainly did a lot of that. Is that who I am? Is that what I want to do with my life? Is that what brings purpose and meaning to my life? And so I still was very grateful for that change. And it meant that I saw diversity in a way that I couldn't have seen it before. I'd had an intellectual kind of preference for inclusivity, but I didn't live it. And I was able to live it. But that comes about because I became very disinterested in what people thought. And I mean profoundly disinterested in what people thought about me, based on any assumptions that they were making, whether I was, homosexual or whatever it was. I became much less interested in that. Whereas I'd probably spent the better part of my childhood and adolescence being very, very concerned about what people thought. Yeah. And so I didn't worry about that anymore. And I think for many people who come out, one of the factors that we have to ultimately reckon with is that we have to be able to come out and understand that we may be completely rejected, but that doesn't mean we're any less. And that's the kind of crisis which builds grit in people. And so I think then you go out into the world, and if you hear the odd homophobic phrase, or maybe someone didn't want to give me a promotion because of some issue with my sexuality or whatever, it might have mattered a bit, but it didn't matter much. Yep. And in fact, I left jobs where I felt that there was like a non-inclusive, homophobic kind of situation. I've got privilege. I can go wherever I want. So I just move on, and I'd say, look, this isn't a good fit, and move on. That happened a couple of times in my career. So you can't disentangle the white privilege from the coming out, but at the same time, I think that I genuinely understood inclusivity in a new way and celebrate it. I mean, it's so wonderful to go to Mardi Gras and other things like that and be surrounded by all these people being themselves, even though I know what it took to get there, and then beyond that, how they might suffer as a consequence in their relationship to the world. And here they are. I would challenge anybody to say that that's a mental illness or some kind of mental defection or some kind of when people are willing to have sacrificed everything to sit in themselves in this authentic way, and this is what it means, and they do that even though they're socially excluded and politically disempowered. It's pretty extraordinary. It tells me that in the matrix of whatever makes us, it must be an important part of who we are. And so to be surrounded by those people on those occasions is nothing less than inspiring.
No, I think that's a beautiful message in the spirit of the Pride Month itself. Yeah. Is there anything else you wanted to say about it? No,
I just, I wish every little person who's growing up who realises there's something a bit different about them. We don't need platitudes like, differences make us great, although that's all nice. What we have to understand is that that certainly from my perspective, this is the one life you've got. And if there's something that's burningly unique about you that matters to you, live it. And, come what may. We actually have to be able to say come what may. because it's got to be that important. And I think in these situations about who we love and how we love, I think sometimes that's getting to the heart and soul of why we exist, in which case it's pretty important. And if you're going to be rejected because of it, there's probably somewhere in the world where there's an open arm. And if you find that place of safety, it doesn't have to be terrible. Your world might shrink a bit in terms of how many people you interact with and where you go. But in the end, there'll be a safe place. I've always found there's a safe place.
Yeah, like there will be people that accept you for who you are, for being your authentic self now. Yeah, I agree. That's a beautiful message. Kieran, I wanted to talk to you about, I guess, currently what your opinion is about how we practice medicine. You could bring your work into this as well. Your book about complexity.
Yeah,
in healthcare.
Complexity and the ethics and sort of entropy of all of that. So I suppose I was surprised in my research to find that when you look at why we do what we do in medicine, there's actually not a lot of sophisticated thinking about that. There are anthropological, sociological, psychological research, but none of it really spoke to me to the axiology, the praxis, the doing. Why do we do what we do? And I think that we use phrases like, because we want to help people, but you can help people in a million different ways. You don't have to be a doctor to help people.
Yep.
So that wasn't the core of it either. And what I discovered through my work was that we often derisively use phrases like, the chaos of ED. And rather than seeing that as a sort of moniker of doom, I looked at it and said, well, hang on, but what if that's what it is? What if it is chaos? So if it's chaotic, if I look out into the world and say, well, what else is chaotic that I can try and make sense about this situation from? I discovered the world of complexity. So complex organizations of structures that somehow overcome this phenomenon that we call in lots of different domains, which have different meanings. It's important to acknowledge that, but we're not going to go into the technicalities. But fundamentally, the effort of life is to resist the inevitability of decay, of entropy, the loss of information, the disorganization, the disorder. In simple terms, the heat death. Everything becomes so spread out that nothing interacts anymore. And that seems to be, in terms of cosmological thinking, that's sort of the direction of the universe in many tens to the 100 years. Okay, so it's a long way off from heat death, but in between there's this thing called life. And Schrödinger wrote a profound paper, which I think probably because of his physics work is less well known. But as a philosophical piece for me, it changed my life. He asked the question, what is life? And so he gave a lecture series in the early part of the 20th century, which was turned into a book. What is life? And he predicted all sorts of things like the crystalline structure of DNA, even though we didn't find it for some 20 or 30 years after. Well. But the point being that life is really about the organization of matter in such a way that we resist this entropic decay. And so using those sort of grand themes and turning back to what we do in medicine, when I started to observe how things get done, I observed, this is what's happening, is that the decisions we make, the technology we use, the way we think about things is fundamentally about changing the entropic relationship. So trying to reduce it to make it manageable. And we have these structures in our system, which both are embodied and in our ways of thinking, which allow us to dissipate increased rates of entropy. And the iconic or the symbol of all intense entropic increase is suffering. And so the title of my thesis was The Entropy of Suffering. And what I was trying to articulate there was the phenomenology, the sort of observable objective nature of entropy, which we see in humans as suffering. And so if we start from that base, everything we do in healthcare is to try and slow down or limit entropic decay, which ultimately, if it's unchecked, will lead to heat death, which is death for us. And whilst death isn't the worst thing that can happen in healthcare, I hope you've learned that much so far. It's not the worst thing.
Yeah.
We clearly actually are much more motivated to avoid suffering. And that fit, as I've talked about, that's fit with other ways I've sort of thought about things over the years from great thinkers that, rather than seeking pleasure, we're avoiding suffering. And that seems to be true of most people's motivations. So it started to all fit together as a inferential logic to say, well, hang on, maybe there's something here. And so I think when we have a structure of understanding, we become capable of asking different kinds of questions. And I find that those different questions posited by this complex entropic and ethical framing actually lead to more humanistic responses to technical issues. And I think that brings us closer to that goal of sort of what we now term realistic healthcare, where we aim to make all action in the things we do in medicine humanistic first, supported by and informed by our technocratic expertise. And so I think that's kind of where I'm landing with this, is that we do things in healthcare to bring humanity to the technology and the processes and the interventions that we are privileged to understand. And in doing so, we actually bring that into service to people who don't need to know about all the technical stuff. They don't need to know. They need to care about, mum's next birthday, or the safe birth of my child, or the end of suffering from my, chronic back pain or whatever it is.
Yeah. And I think I really love that side about you, Kieran, that I guess your life perspective, your book itself, it's very, human-centered in its nature, and it serves to serve the patient, the human, at the end of the day.
Yes,
rather
and
than being self-serving.
Rather than being self-serving, although we're allowed to be self-serving. I don't want to. Things aren't good and bad; they just are. But the goal, of course, is to understand that what we do to another, we do to ourselves.
Yes,
and that's the ethical structure that Dr. Leslie Kuhn and I, my co-writer on the book, who was also my supervisor in my Ph.D., that's what we sort of were really wanting to ensure we emphasise, was that all of this happens in this ethical context, which from our perspective is served by Emmanuel Levinas's views on things, which is that there's this self-other knot of responsibility, that we are responsible for each other as we're responsible for ourselves, and as the other is responsible to us. And so that relationship is immutable, and in fact it informs all aspects of what we do. So if we bring that to the centre, then of course the patient and the doctor are actually equal in that, because we're ethically bound. We're not technically bound. So we can only be equal because we're embodied.
Yep.
Yeah.
So just before my battery ends, I guess one of my friends, he had a question which will be the last question, and then we'll just conclude. So what is your advice on how medical students can become better as future doctors?
It's a couple of things. The first is learn your science. I think we have spent a lot of time in medical education worrying about how to turn you into good humans. And that's an overreach. Medical school doesn't make you a good human. It has very little to do with that. It's got a lot to do with who your parents were, your educational experiences, your life experience. Life will make you a good human. That's what we don't have control over. What we do have control over is whether you're technically expert or not. And I think that a good doctor, first and foremost, is a good technician. That means learn your science, and the rest will come. and it will come when you enter into a relationship with your patients. We can do a bit to help you sort of navigate that, but in the end it's up to factors that are well outside our control. And the second thing is very difficult to do, very easy to say. As Aldous Huxley said, after paraphrasing him, after many decades of contemplating the philosophy of life, he was embarrassed to say the best advice he can give you is be kinder. And unfortunately, I think that's now got this aphoristic, really unhelpful kind of jingoism to it. Oh, be kind. You'll see it scrawled everywhere. It is actually incredibly difficult to be kind, because it means that you are putting yourself in relationship to someone first. It's not about meeting my needs, it's about meeting our needs. How do we negotiate that? Can you imagine how hard that is to do in every interaction? And yet it's the basis for the greatest success in healthcare, is to be kind, to be able to let your own issues, worries, concerns, bad days, bad mornings, bad relationships, to somehow let that sit to the side so that you can give yourself properly to the person in front of you who's in need through their suffering. And when you do that and you act kindly in that way, we actually all benefit. And then perhaps we go back to our difficulties and our crappiness and other things with a slightly bigger heart, and we're better at dealing with that. So I would say that's it. Be technically excellent, learn your science, and then remember that you can always be kinder.
I think that's an amazing message, Kieran. We'll conclude the podcast here. Thank you so much for everything. I really loved having a chat with you.
You're welcome, Gavin. Thank you very much.